Hi, everybody. I hope you can hear me okay. Um, welcome back. So, today we're going to be discussing delirium in the elderly again. And we had left off last week discussing all of the other types of cases that we had gone through how we approach these patients and things like that. And, it's what I'll do is I'll actually post the entire presentation on the group so that if you want to take screenshots of these, you can. Or if you want to, you can just take screenshots of this now so that you know you've got it. So these are the differentials when acute deterioration. These are what we check for in the vitals. And these are what we check for as far as our basics in terms of these patients. So this week, what we're going to do is we're going to concentrate on a case. So initially, when I prepared the presentation, when I presented it before, we sort of gone through the case in the middle and then picked up with it. But in any case, let's look at this now and let's try and have a look and see. So here we have this 73-year-old male patient, it's a real patient who had come in. He was brought into the A&E with a history of loss of energy and appetite for 2 days. The patient was drowsy, the patient was weak. He was known with a previous CVA, right hemiplegia due to poorly controlled hypertension. He was bedridden as well. So the patient had been talking to his dead grandmother and throwing anything that was given to him. So, this patient unfortunately was actually um, admitted for 72-hour observation, because he was objectively hallucinating and he was violent, even though he was weak. It's quite sad that this actually happened to this elderly gentleman. And I mean, if this patient were to walk into you now, knowing what you know, would you admit him? And the answer is no. I mean, even now when you look at it, it's a relatively straightforward case that the patient has. We've got to look at the differentials before we can go to the psychiatric cause. So if so with these patients, like I say, the psychiatric diagnosis is always there, but it's right at the bottom of your list. And some patients may have more subtle signs, but don't just jump to that psychiatric diagnosis, right? So we already have multiple possibilities with this patient, but let's be systemic and learn. So in the history, what do we want? We want a drug history because he's hypertensive, he's bedridden. Is he taking anything else? We want a history of the CVA in particular. We want to know what happened, when was it, how extensive was it, what did it affect, things like that. We want to know if there's a history of psychiatric illness, because for all we know, he could have been a psychiatric patient prior to having the CVA as well. This could be a manifestation of his psychiatric illness, but it could be due to the CVA. So it may sound straightforward, but it's a lot of things that, in this case, one asks. We want to know about his baseline function as well. So there's quite a few things that we need to ask this patient, and we need to and check with the family about and see exactly what's going on. So yeah, let's just try and just get to that, right. Yeah, so we were talking about the history, sorry. And then in any case, elderly patients may have a primary low level or they may have a primary high level of function. It's important to know how have they changed from their baseline function. And previous or concurrent illnesses are also very important. And it's very important to actually ask about this. So in this case, is this patient normally self-sufficient and now becoming normally, is now poorly responsive? Or is this patient always been poorly responsive? So these are the type of questions that we need to ask. So is the patient under supervised care? But even so, is the patient displaying acute changes? And any acute change in baseline function is a cause for concern in an elderly patient, not just in terms of psychiatry, but in terms of, well, investigation. Is this an infection? Is this a tumor? Is this a underlying metabolic disease? Is this an acute exacerbation of a chronic illness? And in fact, there's so much to go through before we get down to the point of calling it psychiatric. Okay. All right. So let's move on to the next slide. So in this case, it's outpatient. So yes, that is me in the slide if you're wondering. Uh, no, not him. I'm actually the young Asian lady on this side. I'm just kidding over there. So in this case now, we had our patient. This was his BP on arrival. So the patient's in shock already, a heart rate of 122 with a temperature of 39.3. Now, even if you've never covered shock before, this should, if you've got a baseline medical knowledge, this should tell you that we're looking more at sepsis, all right? And we're looking at septic shock combined with possible dehydration and hypovolemia as well. Sorry, not his STAS, his SATs were 93%, and his glucose was 4.7, so it was reasonably okay. And a low glucose is something that you would look out for. Hypoxia, remember, is something you would look out for. Now, he was nitrite positive on urine, mild dehydration. So what's your diagnosis in this case? So your diagnosis in this case should be infection. I mean, that's what you are looking for. Okay? So in this case, this patient was pushed through. Now, this was a few years ago, and it's not a patient that, is like in the last little while. So, I know sometimes people look at these and think, oh my God, this is a patient that I saw. Now, this is actually a patient from a good few years ago. It's just that it became quite a major case for our hospital. So that's why I like to teach people about it. Okay. So in this case, this patient has a UTI, most likely, and needs to be treated as such. So what are the things that we are looking for from a neurological point of view with most of these patients? From the neurology, we're looking for infections, we're looking for CVA. And don't forget your ENT and ophthalmology exams, because those will often tell you, if there's an underlying infection in those areas as well, that can easily lead to meningitis, underlying brain abscesses. There's so much that can come out of it. And unfortunately, without further investigation, it's impossible to come to a complete diagnosis, but at least you can come close and you can say, listen, I suspect. And what you're doing is you're not, how do I explain it? You're not turfing the patient to the medical department or the surgical department or the neurology department. You're actually giving this patient a chance at life. Because remember, these are patients that, if they end up in a psychiatric psychiatric area, a lot of the times, I mean, we know, especially those who have been working in medicine for quite some time, generally the patients that come to you tend to treat them in the same way because you're used to seeing patients of that time. So a surgeon approaches from a surgical point of view. An obstetrician approaches from an obstetric point of view. So in other words, that person has a hammer. Their hammer is their surgery or their medicine or their psychiatry. And to them, every problem can be solved with that hammer. And unfortunately, if that hammer is not working, they often get confused. Now, this is not something that is to be scoffed at and laughed at. This is common throughout medicine. It's something called bias, medical bias, training bias. There's a lot of biases that go into it. And if you study ethics, then you learn about it. So what happens is that a patient who ends up in a psychiatric section, the nurses are trained to look at that patient from a psychiatric point of view. The doctors are trained to look at that patient from a psychiatric point of view. So they start looking at the patient from that point of view. Now, everybody could argue and say, yeah, but aren't they doctors? Shouldn't they know? Yes, they should. But it's just like if a ruptured ectopic ends up in a surgical department, the surgeons will first think it's a ruptured appendix. Then I mean the surgeon doesn't know what they are doing. It just means that they are looking at it from their point of view. So by making sure that you look at all of these things, you're actually saving this patient. Now we're going to concentrate a bit more on the neurology. All right. So let's look at what's happening over here. So this is what happens with the right parietal CVA. All right. So just to remind you, this is occipital lobe, temporal lobe, parietal lobe, frontal lobe. All right. So now we're looking at the parietal lobe. The reason why I say this is because this is often something that presents in the elderly. Now, it's not a common CVA. When I say that, the reason why I say that is because of blood supply and how it can get affected. But our patients who come in as elderly patients are more prone to vasculopathies, vasculitis, vascular injury, thromboembolic phenomenon. And despite there being a more traditional CVA model, they can develop parietal CVAs. Okay. So what happens when you have parietal CVA? You have a loss of peripheral vision, right? Loss of hand-eye coordination. Now, this in itself, well, when I say loss of hand-eye coordination, there's actually a lot of what you might call it, difficulty with the patient actually picking up things, putting things in their mouth. It may be difficult to pick up in a small examination, but you may start noticing it if you spend a bit of time with the patient. Then here we have a stereognosis, which of course everybody knows, so I don't have to explain. All right. No, I'm just kidding. So it took me quite some time when I was studying, when I was first reading this, I was like, the heck is a stereognosis? So it turns out it's an inability to distinguish objects by touch alone. So you and I, if I give you a golf ball and I give you a tennis ball, you can easily tell the difference between the two. If I give you a stone and a sponge, you can tell the difference. They can't tell the difference, right? And then finger agnosia, it's what you call it, difficulty in identifying their finger. So if I ask you to lift up your index finger, you can do it immediately. Small finger, do it immediately. They can't. They just can't do that, right? Hemispatial neglect, which we'll talk about just now, and inability to tell right from left. Now, it's not common. This one that I'm showing you is not common. We've discussed more of the common ones in the previous video, and we've discussed a bit of our patient as well with the UTI, so that you can see when you approach it from the point of view that this is not psychosis, it becomes very obvious that it's not psychosis. But now we're just talking about this. So we're going to watch a little video, and it just gives a little indication about hemispatial neglect. So we're just going to have a look at that. Okay, so let's watch that and see what it says.
Yeah, because Alan's middle often isn't it?
The middle is the right.
I used to always eat on my right side, but not on the left side. Just leave that.
Give her a dinner plate and she'd only eat the vegetables and leave the meat, which is disappointing because I was a cook.
So if he starts a picture, it can not fit in the paper if he gets over to the left, because he hasn't left enough room.
Spatial neglect is a syndrome, that is signs and symptoms that patients most frequently have after stroke, but sometimes in forms of Alzheimer's disease, where they ignore one side of space. So people, objects and sounds on one side tend to get ignored, and the patients who have it tend to be drawn to the other side. And this can extend to things like the food on the plate in front of them. They'll only eat food on this side and then say they're finished. It may extend to parts of their own body, so when trying to shave, they may only shave this side of the face and miss out this side, put makeup on.
So you can only see from across there?
Yeah, from there to there. That's my vision.
So what's going on in the other half?
Nothing.
There's nothing at all?
Because often I'd come up from this side to give you something.
Anybody can creep up my left, I wouldn't know they were there.
See anything.
I can't sense them.
So if you just look at me and just point at the finger that moves, okay? Or say both if both. Tell me which finger moves.
First one.
Yeah.
That one.
Okay.
Yeah.
Look at me.
That one.
Okay. Look at me.
That one. That one. That one. That one. That one.
Great. That's fine. They tend not to describe the condition, to be honest. One of the most intriguing things about it is that this sort of loss of attention for one side of space doesn't leave a great gaping hole. And that's why it's very useful to contrast it when someone's got what's called a hemianopia, which is a primary sensory deficit. They can't see that side of things, and they know they can't see it, so they're constantly moving their heads like that. Whereas patients with neglect are unaware of their deficit, that they're not even aware that they're missing something, because their sort of imagination of space has gone on that side too.
Does he have a name?
I haven't thought of one.
I can stand right next to you, can't I? You can't sense one there.
No, you can't. If you told her to look, she'd actually look around that way, like that, right round on the right hand side and then come back to central. She wouldn't actually think about coming and looking round to the left as well.
People often say, why don't you just tell them to look to the left? And relatives can be very frustrated about this too. And I think you've got to be aware that the process of attention and these higher visual areas are involved in the representation of space rather than just seeing things where they are. See the lines there?
Split them in the middle.
Yeah, that's one end, that's the other end. Show me where the middle is. Mark the middle for me.
I was only looking at a line from there to there. It's in the middle of my line, not the middle of your line.
So the first time I saw you, that's where you were marking the centre of the line as well. Patients realise something's wrong when things are pointed out to them over and over and over again. So in a way, I think for them it's slightly abstract, that they know that there's some problem on the left-hand side and they're not aware of that problem, but they know everybody's telling them they have to do something more on the left. And so they use strategies and things like that to try and overcome the problem without really being able to appreciate it in its fullness.
I remember getting those word search books, and I remember it was only one side was always ever filled in. Yeah, and then slowly she got better and better at it, because I used to say to her, Colby, you know, I'm not getting value for money here, you're only doing half the page. Yeah, so slowly she learned that, yeah, do the left side first and then come back to the right.
Some people have it soon after their stroke, it gets better within a few weeks. And then another group of people have it long term and learn strategies to overcome it. So if you probe deeply, they still have problems with attention. Even that bias may go away, but they still have deep problems when trying to find things, and then they also tend not to remember where things are after they've looked at them. They have poor working memory for space as well. So a lot of these deficits don't recover, although people can use strategies to overcome them.
Give that a police if they find you. It's good.
So I hope everybody enjoyed that. I must be honest, when I was first studying emergency medicine, this was one of the most fascinating topics that I came across, not this hemispatial neglect, but just spatial orientation. And I wanted to tell you, if you ask somebody who just enjoys learning about how complex the brain can be, just look at spatial recognition and spatial orientation. It's amazing to see how we just glance over it, but it can actually tell you so much about the brain. But in any case, most of the time, if you're working in an emergency setting, you don't really have a chance. It may be something you notice, but, you know, as I pointed out, parietal CVA is not a common thing, and the hemispatial neglect is just one part of that. So now we're just going to go through quickly some other things that you can look for that may point to reasons as to why your patient may be displaying delirium or even acute psychotic symptoms. So in the neck, we've got to look at the thyroid. We've also got to look at the carotid. So if there's any murmurs, any bruise, if the patient has any large carotid, things like that. Even look for lymph nodes, any potential space-occupying lesion that may be causing hypoxia or diminished cerebral blood flow. And any goiter warrants investigation. So if a patient has a goiter, please make sure don't diagnose them as a delirium or a psychosis. Okay. So the nice way that I like to tell people how to look at it is delirium is a symptom. Just like cough, you wouldn't admit a patient with cough, or you wouldn't admit a patient with pain. It's a symptom. In a young person, and I suppose we've overstepped from delirium. We are talking about psychosis in a lot of ways. It's become a more generalized topic, but it was just delirium is just one of the more common presentations of it. So in any case, I hope you guys understand what we're talking about. This is please don't worry, there's no pathology here. This is just a chest x-ray. That is mild pathology, I lie. But it's a pediatric x-ray. It's just to illustrate the point that you've got to look for respiratory infection, and especially COPD, when it comes to hypoxia. And in these days, unfortunately, COVID-19, long COVID, we've got to look at things like that in the elderly. Tumors, as usual, as you've mentioned, right? And then in the cardiac sphere, we're also looking for murmurs. We're looking for ischemia. So we're looking for, basically, there is something known as cardiocephalic syndrome. It's a lovely thing if you want to go and read about it. I don't want to trouble you guys with it too much. But cardiocephalic syndrome talks about pain related to MIs, headaches related to MIs. But there's another part of the cardiocephalic syndrome which also talks about delirium. So in other words, psychosis secondary to ischemia, it's not common, but it can happen. However, more commonly in your elderly patients, valvular disease. So if your patients now are developing, especially aortic stenosis, aortic recurge, which are the most common ones, there's aortic valve calcification. There's so much that starts happening at that age around that aortic ring that it can lead to emboli and vegetations and, things like that. And that can, it can diminish output, especially with aortic stenosis and to a lesser degree, aortic regurg. And then, of course, you can get the cardiomyopathies as well. So anything that affects the muscle size in the heart as well, that can also lead to all of these things as well. Right? My feeling is that any elderly patient presenting with anything should have an ECG. I know it's not always possible, but in my experience, it's really something you should do because it's amazing what you can pick up sometimes. Okay, but it's not always possible, and it may just be making extra work for nothing. But when you actually delve deep into these subjects and you start to understand how you can miss certain things. So in the abdomen, we look for anything, masses, evidence of bleeds. You've got Cullen's and Turner's, signs and things like that, and Fox's sign and things like that, where you're looking for bleeding retroperitoneally, acute aneurysms, abdominal aortic aneurysm, although not a cause of delirium, but the pain may cause a delirious state as well. Infections, hepatosplenomegaly, pointing to other underlying pathology may also have and of course the genitourinary tract as well. I remember one of my greatest regrets is a patient that I had early on in my emergency career who had an abdominal aortic aneurysm and came in, and she was delirious because of the pain, and she was complaining of abdominal pain. She was quite elderly. She was in her 80s, and she was next to me, and we gave her something for pain, and I started seeing another patient, and she passed away, next to me, and I always regret it because after that, when we started to CPR and you could feel this mass in the abdomen, I realized that AAA, it's always one of those things that you kind of regret that, if I just paid a bit of closer attention, and things like that. So anyway, what about the peripheries? You look for anything, any infections, toes, fingers, nose, penis, vulva, ears, anywhere there could be something that could possibly lead to septic emboli, any abscesses, especially within the danger triangle. So the danger triangle is basically from midway here, all right, on the eyebrows, down to the, I can't remember what you call this now, of the lip. It's got a specific name, sorry, just slipped out of my head. So if you can imagine a triangle like that, those are very common to the cavernous sinus thrombosis, septic cavernous sinus thrombosis is very common over there. And any facial tumor has a high possibility of causing delirium as well. But truth be told, even respiratory tumors, airway tract tumors, these all have the potential to. And of course, you get neoplastic syndrome and things like that, which can also lead to acute delirium in the elderly. Okay. And then, so what do we do? So we've been talking about this in very generalized terms. In other words, looking through all of the huge amounts of things. And let's be honest, if you're working in an emergency department, you can't do all these investigations and you can't reach all of these conclusions. So what are the basic things that you can do? I would say for any elderly patient presenting with acute delirium, you're never going to remember everything that we've talked about today, but at least a urine dipstick, chest X-ray, ECG, CT if indicated. All right. When is it indicated? If you find anything that is suspicious. All right, where you suspect that there may be something intracranial, and a blood gas. All right, just a simple blood gas. The reason being, especially in elderly patients, I'm not going to go into it because it's a whole lecture on its own. Look at the lactate levels, and if your lactate levels are high in an elderly patient with delirium, get your physicians involved immediately. Okay, so I hope this kind of makes it a bit easier. It's a difficult topic, but I hope this has helped a little bit. So what is the management? You treat the underlying cause, which is the thing. In other words, don't admit this patient for psychiatry. admit this patient where you suspect there may be an underlying problem. And what I will tell you is, working in an emergency setting, should you call a department and they say, no, this is psychiatric, let them note it down. Because if something happens to that patient, you are then covered medically. In these patients, avoid heavy sedation, because if you do reach a situation where in a lot of them you do need to calm them down, all you are looking at is giving them haloperidol, 2 to 5 milligrams IMI. That's it, nothing else. Now you may say, okay, we don't have access to haloperidol. What do we give? We give low dose Valium, 1 milligram, 2 milligrams. Sometimes I've given them 1 milligram of Valium or 2 milligrams of morphine and kept them on oxygen. And I've noticed that it calms them down quite well. The sad part is that it does respond well to antipsychotics, especially chronic delirium. It responds very well to antipsychotics. But acute delirium also responds quite nicely to them. And that in itself gives you a weird picture, because it's responding to antipsychotics, but you're saying it's not psychotic. But I hope you understand why. We're only treating the delirium part of it. You're not treating the underlying cause in that case. So your patient will be quiet, your patient will be under control, will be calm. So you will be able to then sort them out. Okay. And if it's chronic delirium, then the patient, of course, needs to consult psychiatry. But it shouldn't be a primary psychiatric diagnosis. You should look for other things, and 99% of the time you will find something else. And you should go through everything and not find anything and admit the patient to psychiatry. You've covered all your bases. It's a sad thing to say, but unfortunately, we do have to practice defensive medicine. And sometimes you have to be able to show that, listen, I did the best to my ability with what I have. I don't have a CT MRI available to me. I don't have angiograms. I don't have a cath lab. I don't have this. I don't have that. I don't have that. So I did the best to my ability. I couldn't find anything to suggest another underlying organic cause. So that's why I eventually went to the psychiatric diagnosis. Should something happen, of course, you are covered. But from an ethical point of view, you're also covered because you did the best that you could. Okay, so I hope that helps. I'm also getting back into the swing of things as far as presenting and all of that again. So my apologies if it's not up to the usual standard, and I hope it will get better as the weeks go on. I think also sometimes the pain medication does make me a bit woozy as I'm presenting, and I forget what I was talking about, and I do ramble on, which I've been told I did in the last one, so I apologize for that. And that's just a little joke to finish off, especially when we work in the emergency department. Yeah, I hope you guys enjoyed it, and we're going to do an ECG next week. And I hope you all tune in.